Good afternoon, everyone. This is Rich Pizzillo, NEHA's Executive Director. We are so appreciative that you are joining us for our first live webinar. The webinar series that we are launching today is coming from a direct response from our community. We were asked following FallFest if we could provide information for those that are not at FallFest to community members, in addition to provide information that was at our meetings on a channel like YouTube. So we're really excited to have this as another service to our community. Before we get started today, I'd like to go over a few webinar points and helpful hints. So today's webinar will last approximately about 30 minutes, and there'll be time for questions. We welcome your participation and questions. Your audio will be muted by the system for the entire duration of the webinar, as this will help eliminate background noise that may disrupt the presentation. However, if you have a question, we encourage you to use the question box on the bottom right-hand corner of your control panel. Once you ask the question, we will then pass these questions along to our speaker. NEHA would like to acknowledge Dimension Therapeutics for an unrestricted educational grant that is providing this educational webinar today. So without further ado, we'd like to welcome our speaker to today's presentation, who also spoke at FallFest and who has been a great friend of the bleeding disorder community. Dr. Stacy Croteau is a pediatric hematologist and clinical researcher at Boston Children's Hospital, where she specializes in bleeding and clotting disorders. She completed her undergraduate and medical education at Brown University and then pursued training in pediatrics and pediatric hematology oncology at Boston Children's Hospital and the Dana-Farber Cancer Institute. Dr. Croteau joined the Boston Hemophilia Center as the Associate Director in 2014. She currently serves as the primary investigator for several industry-sponsored and investigator-initiated clinical trials and as the National Chair of the American Thrombosis Hemostasis Network, ATHN, and the National Hemophilia Program Coordinating Center, Transition Working Group. So without further ado, Stacy, I'm going to turn the presentation over to you.
Excellent. Thank you so much, Rich. It's really a pleasure to be able to join you all for NEHA's first educational webinar. With so many exciting advances in hemophilia therapy, I'm sure there's going to be many more of these to come. Today, I'm pleased to be able to delve back into gene therapy, as Rich mentioned, a topic that we started to discuss at FallFest. So our plan for today is to review some key concepts that I hope will provide you with a better understanding of how we're using gene therapy for hemophilia. So over the next 30 minutes or so, I'm hoping to help you answer these questions. What is gene therapy? How is gene therapy performed? How is gene therapy being applied specifically to hemophilia? And what are the results of the hemophilia gene therapy trials so far? So first of all, what is gene therapy? In a simplistic sense, gene therapy is just the introduction or potentially alteration of genetic material, DNA, into a cell or an organism with the intention of curing or treating disease. So we all know that people are complex animals. We are composed of many different organs, and the building blocks of those organs are tissues. And in turn, those tissues are built by cells, which are really the smallest building block of our bodies. Within these cells are, in the center here, the nucleus, which contains all of the primary DNA of the cell, which is arranged into chromosomes, which is then subdivided into small genes. And the purpose of all of the DNA is to give the cell instructions on how to make the building blocks that we need to then have more cells, develop specialized tissues that form things like liver and lungs and heart that make up each of us. The genes themselves encode specifically for proteins such as factor VIII or factor IX in hemophilia specifically. Amazingly, gene therapy really has the potential to treat or cure many diseases. Here you can see an outline of a person highlighting many different organ systems, everything from skin, where you see some endothelial cell pictured here, to brain, heart, and blood vessels, and liver, just to name a few. And really, one of the main focuses of gene therapy initially has been to treat diseases that result from a single gene defect. And we often refer to these diseases as monogenic diseases. And so those can be diseases that affect the brain, such as adrenoleukodystrophy. Those can be things like hemophilia that affect our blood. It also includes many other types of diagnoses, including cystic fibrosis, severe combined immune deficiency or bubble boy disease, other types of immunodeficiencies, and other diseases that arise because one single gene alteration has led to the lack of a protein that was needed to do some type of important function, either create a clotting protein, as in the case of hemophilia, or perhaps create a protein or enzyme to break down certain types of waste, such as in lysosomal storage disease. To meet this demand of a lot of different types of diseases, there's actually been several different approaches to gene therapy that are currently in development. And broadly speaking, you can think about these as direct gene delivery, cell-based gene therapy strategies, as well as gene editing. So a direct delivery model looks basically like the gene therapy construct, the DNA that you're hoping to get into the person to correct the problem, is simply infused directly into the person. And as we go through this talk, we'll speak in more detail about exactly which components and which processes need to happen in order to make that successful. But it's generally a straightforward type of procedure where it's usually a one-time planned injection to put the DNA into the person, have it go to the cells that it needs to go to fix the problem. Cell-based gene therapy uses a similar general concept, however, there's a few more steps involved. So for cell-based gene therapy, the actual introduction of the gene therapy vector and the target DNA that we'd like to include, that actually happens outside of the person. So usually some type of cell is taken from the person. This may be skin cells, this might be bone marrow cells, for example. And then once we have those cells are treated with the gene therapy mechanisms. The cells are then cultured, and the cells that best represent the successful gene therapy, cells that are actually making the protein of interest, are then reintroduced into the person. Oftentimes, in addition to just reintroducing these cells, other medications are needed to suppress the immune system, at least temporarily, to help these cells be able to find the place that they need to go to and to proliferate to work without the body destroying them before they have a chance to do so. The last type of gene therapy category is gene editing, and this has become increasingly heard in news and media. So things that would fall into this category are things like zinc finger nucleotide editing, the becoming more and more famous CRISPR-Cas9 system. So rather than just introducing DNA into a host as in direct delivery or using a cell-based mechanism, the gene editing is a bit more complex, as there are multiple components that actually need to be introduced. There are special molecular scissors, for example, that go to the right place in the person's DNA to make cuts to cut out the undesired gene, and the DNA material that's needed to make the desired protein is also introduced. Why so many different approaches? Well, the answer is really that there are genes of all different sizes that make a whole variety of proteins. And where we need this genetic material, these genes, to end up in order to make the proteins in the place that they need to be, requires them to go into different cell types. And depending on what cell type you are hoping to be able to put DNA into and how big the DNA construct is that you have may require one type of gene therapy versus another. In some cases, we're dealing with small genes, and so each of these potential approaches could be appropriate. Also, the amount of protein that one needs to make to correct a given disorder varies. So for example, in hemophilia, we know that even a relatively small amount of protein expression may increase people's factor levels from less than 1% into the 1 to 5% range and in the 5 or greater percent range. So even a little bit of factor protein, if it gets you of factor 8 or factor 9 rather, if it gets a person up over the 1% range, you may have an improvement in your overall disease phenotype, meaning you may have less bleeding or you may no longer need the same amount of prophylactic infusions, whereas in other diseases, a more robust amount of protein may be needed to be sure that the job is done for that disease. Just to give you a brief sense of the timeline of gene therapy has been many decades in the making. Really, the 60s, 70s, and 80s saw a lot of the preclinical work, understanding of different components that are necessary in order to make gene therapy successful. And then in the late 80s and early 90s, we started to see emergence of a variety of gene therapy trials. Highlighted here are some gene therapy trials that actually use a cell-based gene therapy approach that I mentioned in the center of the previous slide. Most of these early gene therapy approaches were really targeted towards immunodeficiencies. These are particularly severe disorders that cause significant illness and death in young children. From these early studies, there were some lessons learned in terms of safety and lessons learned in terms of how people differ from animal models with respect to gene therapy and things that we can expect to see. So just to highlight a few of the safety things that are often mentioned in relation to gene therapy, one happened in 1999, and the headline read something to the effect of adenovirus vector causes patient death. And in this situation, people were trying to treat a disease called ornithine transcarbamylase deficiency, or OTC. And this is actually a metabolic disorder where chemicals in the body, when you're missing this protein, are not broken down sufficiently. And so in young babies, it can cause actually significant neurologic problems. In milder forms, children grow up with slightly less deficiencies. But it was a severe enough disorder that really many of the early gene therapy trials were interested in focusing on it. This gene therapy used a direct approach, so there was an adenovirus vector, and this vector was directly injected into the liver. In the case of this particular young person, within a few hours of treatment, he happened to develop fever, signs of liver injury, and basically his whole body became very inflamed, causing many of his organs to stop working appropriately, and then he unfortunately passed away. When people went back to look very carefully at what seemed to have gone wrong, one of the things that we learned is that adenovirus, which actually can cause mild disease in humans, when reintroduced in this setting, since his body had likely seen adenovirus before, resulted in an overwhelming inflammatory response, resulting in all of the different things that I mentioned. And so adaptations to use alternate viral vectors and slightly alternate approaches have been used subsequently. Another safety issue that made press was in the early 2000s, where a retroviral vector was attributed to inducing leukemia. This situation happened in the context of a clinical trial that was treating severe combined immunodeficiency, or bubble-blight disease. This type of gene therapy was the cell-based gene therapy, where they were using a retroviral vector. And as I had mentioned previously, they actually take cells from the person, do the gene therapy, and then reintroduce the cells into the person. Initially, it was heralded as quite a success because the gene therapy worked quite well, and the immunodeficiency in several of the patients resolved. Unfortunately, a few years after that initial success, a few children or a few patients developed leukemia-like disorder, so abnormal growth of white blood cells. And what they discovered is that while the vector was selected and anticipated to insert into the person's DNA in a specific place, there were cases where the vector was actually inserting in other places. And in the case of these patients, actually inserted in a place that changed the cell's regulation of how often to proliferate and then caused abnormal proliferation. So similar to our first case in 1999, understanding how these different vectors work in humans led to several modifications and then subsequent gene therapy trials. And amazingly, we actually have licensed gene therapy products available through Europe. So the European Medicines Agency has approved 2 gene therapy products. The first was approved in 2012, and this was a product to treat lipoprotein lipase deficiency. This is another metabolic disorder where patients who don't have the right protein are not able to break down fats appropriately. This type of gene therapy used that direct approach that I mentioned first, using an adeno-associated viral vector, so AAV, which is actually quite distinct from adenoviral vectors that I mentioned in the safety slide. The other medication, the other gene therapy is something called Trinvelis, which was just approved earlier this year. And this is a product that is a cell-based gene therapy to treat bubble boy disease or SCID, that severe combined immunodeficiency. The reasons that they have been improved in Europe and not the United States have a lot to do with where clinical trials have taken place and the patients who have participated. But I suspect one or both are looking to submit in the United States and maybe trying to get FDA approval also. So when we think about gene therapy in hemophilia, actually each of these modalities that I had mentioned before, direct delivery, cell-based, and gene editing, are actually all investigation in gene therapy. We're going to focus primarily on the direct delivery mode today, as this is the modality that has the most clinical trials that are actively ongoing and has really made the furthest strides in hemophilia. So we can talk about some of the actual in-person data for these ongoing trials. The cell-based gene therapy techniques are coming to clinical trials very soon, but we'll have to have another session, I think, to talk about when that would be the right cell-based therapy, when cell-based therapy would be a good choice for hemophilia and some of the specific subpopulations that may really benefit from this type of approach. And similarly, gene editing is just coming to clinical trials also, but because of a number of different considerations and mechanistic differences and our limited time today, I'm not going to focus on this approach for this talk. So what are the components of direct delivery gene therapy? So I had shown you previously a picture of a man with little green shapes outside ready to insert. So what are we really looking at? So the first component to know about is something called the vector. And the vector is really our delivery vehicle. This is the special little coating that we put around our very precious DNA that we hope will stimulate the cell to make factor VIII or factor IX to protect it and help the DNA get where it needs to go. Viruses are actually perfectly designed for this task. So when most of us think of viruses, we think of fever and cough and cold and not feeling well. But it turns out that if you construct the virus or use the right components of a virus correctly, they work really well for gene therapy. And that's mainly because viruses are not their own independent beings. They cannot grow or reproduce apart from a living cell. This is in contrast to bacteria, which are their own little entities. Viruses need cells, need a living host in order to replicate and to continue to exist. And to do that, they have a whole variety, as you can see by the different shapes and colors attached to these pictures of viruses. They have a whole number of mechanisms that help them invade different types of cells, and then within inside them, machinery to help replicate the DNA that they have within inside to continue to survive. So our goal is to use the outside components or mimic the outside components of these viruses, and then rather than having viral DNA on the inside, that in the case of some types of viruses like adeno might make us sick, instead we have the DNA that makes the protein that we're interested in expressing in the body to make a person's disease either better or completely cure them. But as I mentioned, some viruses like adenovirus in and of themselves can cause human disease. Other viruses like adeno-associated virus have many of the same features in terms of invading cells and replicating to survive, but don't cause diseases in humans specifically. So vector is one of the important main components that you'll hear about in discussions of gene therapy. The other major component is something called the expression cassette. So this is really, you can think of as the innards of what we're sticking into that viral vector shell. And so inside is the therapeutic transgene. So this is the DNA that codes for the protein that we're interested in. And also included are directions for the cell to make the desired protein. So when we have this factor VIII or factor IX DNA, for example, we still need to be able to have instructions so that the virus, the viral capsid, the viral vector, knows to put that DNA inside it. And then also, once the virus gets to the cell that it wants to invade and delivers the DNA, the right additional machinery to tell the cell, yes, please make the proteins from this DNA, that all of that material is there. And so to do that, there is actually a number of components to the expression consent. So on either side, some of this delivery and packaging information is included in these ITR regions. There's a promoter region of the transgene, and this helps, as the name suggests, promote the expression of what comes next. And this is the coding sequence or the DNA. And often there can be small additional modifications within this region that help improve the rate of protein development or the longevity of the DNA constructs. And so, for example, with the adenovirus that I showed from the previous slide, this is a relatively small virus, and you can see an example of what the expression cassette would look like for this virus. The 4.5 kilobases is just an indication of the approximate size of DNA that can fit within the usual constraints of the adenovirus. Other viruses, such as the adenovirus and lentivirus, as you may glean from this picture, are a bit larger. And so different viruses may be able to hold genes at different lengths. And the reason that we like AAV viruses, particularly for hemophilia, is that they're small viruses. They don't cause human disease. And there's actually a number of different subtypes of AAV viruses that preferentially go to different tissues. So for hemophilia, we're particularly interested in viruses that would go to liver cells. But as I mentioned, there's a number of other diseases that are looking at AAV gene therapies, and they may rather select an AAV subtype that goes preferentially to muscle or to the brain, for example. And you can engineer them to carry genes, as we've just reviewed. So how is gene therapy performed? So we talked a little bit about the expression cassette. This is illustrating a factor IX gene construct, for example. This expression cassette gets packaged within an AAV virus-like capsid. And then there's a number of manufacturing and quality control steps, but ultimately that vector with the cassette ends up in an infusion bag ready to infuse into a patient. And so as you can see from the picture of the bag, this hangs very similar to blood products and IV fluids, and then tubing is connected to an IV, and the gene therapy product is simply infused via an IV. Once the infusion happens and these little vectors are circulating in the blood, we expect the AAV vectors that we're using specifically for hemophilia to hone to the liver cells or hepatocytes. The vector coding that we spoke about makes it an hepatocyte. It does what it does best. It invades the liver cell. And then this outer capsid that was so important for making sure that the DNA was protected in the bag, for making sure that the DNA was protected as it circulated around to get to the liver, now it's done its job. So the capsid falls away, and then what's left is the little piece of DNA construct. And in the case of AAV vectors, what happens is the DNA forms a little ring, and we call this episomal expression. So the DNA sits inside the nucleus with the person's other DNA, but it sits separate from the person's baseline DNA. It uses the machinery in the nucleus to ultimately express proteins, but as I mentioned, it stays separate. There are some viruses, and this is true of the immunodeficiency gene therapy trials that we spoke of earlier, where the virus itself not only gets the DNA into the nucleus, but then the DNA construct of interest actually integrates right into the host's DNA, the person's DNA. Similarly, for the gene editing technology, the cutting of the abnormal genes and the insertion of the new genes happens right in the host DNA. So the AAV vector approach is a little bit different in that regard. So we talked a little bit about this, but how does the gene get to the right place? So I mentioned that there were several subtypes of AAV viruses, and you can sort of see them depicted here. And as I mentioned, some prefer to go to the heart, the skeletal muscle, the liver. There are some that also preferentially are able to go to the brain if injected appropriately. And so selecting the right AAV has a lot to do with the underlying disease that you're trying to improve or cure. So we spoke a little bit about the cell-based and immunotherapy gene therapy, but what about hemophilia and AAV therapy? So the discovery of AAV actually happened way back in the early 1960s, and over the subsequent decades, a lot of investigation went on to understand the components of AAV and the genes contained within AAV in ways to leverage that particular virus to be a vector for gene therapy. The first AAV gene therapy trial actually was in the mid-'80s, and that was a cystic fibrosis trial. But hemophilia was hot on the tails of those early cystic fibrosis trials, with gene therapy trials starting in the sort of late 80s to early 90s by the time some of the results were reported. And I've listed 3 of the early AAV hemophilia gene therapy trials here. Some used skin fibroblasts as a mechanism for trying to get the gene construct of factor VIII or factor IX in this case to be expressed. Others used the AAV mechanisms like we've already spoken about. One tried to inject it intramuscularly as opposed to intravenously. Another tried to get it even closer to the liver and inject it right into the hepatic artery. And one thing that all of these mechanisms had in common is that they all had some transient expression, that it was a pretty short-lasting effect. So on the one hand, this was quite exciting because it proved that at least for a short amount of time we could make this work. It was disappointing that it did not last long. However, scientists had a lot of great hypotheses about changes, tweaks that they could make to the overall system to both improve the levels that they were seeing as well as hopefully increase the duration that they were seeing them for. And so in 2011, excitingly, we had our first successful AAV gene therapy for hemophilia trial published, and this actually came out in the New England Journal of Medicine. So let me walk you through this graph. So as is common of most early drug trials, whether it's gene therapy or other therapeutics, we typically start with what we think is a small but safe dose to test. And then depending on the how well the patients do, primarily from a safety perspective, but potentially also from an efficacy perspective in gene therapy trials, we then increase the dose. And the hope is that we're able to maintain few symptoms, a safe product, but the thought that a higher dose might ultimately lead to better outcomes. And so here, you can see that this particular trial had 3 dose ranges. So they started first with the low dose. Those 2 patients were treated. They had the results, and then they went to the middle dose and then the high dose. And so what you can see going up along the y-axis here is the factor IX activity level. And what you can see going along the x-axis is the patient number. So there were a total of 10 patients in this study. All of the patients when they started had severe factor IX deficiency, severe hemophilia B. So we would have expected their levels to have been less than 1%. And what you can see is even in the low dose cohort, patients actually were able to increase their baseline factor IX levels over 1%, in sort of in the 2 to 3% range. Similarly, in the middle dose cohort, patients increased their factor IX levels perhaps a bit more than the low dose. And then in the highest dose levels, we actually see, again, some variability, but overall increasing amounts of factor IX levels. And follow-up data was published from this study in 2014, and I suspect that they'll have additional follow-up data coming soon that have actually been able to show that over the duration of years, these factor IX levels have been sustained. So effectively, even in this early gene therapy trial, what happened was all of these subjects who had severe hemophilia B were able to become either moderate hemophilia B patients or in a few cases, mild hemophilia B patients. And this actually is really profound because we know that the annual number of joint bleeds decreases according to factor activity. So this specifically was done in a hemophilia A patient group, so we see factor VIII activity as opposed to factor IX activity. But we expect that by and large, a similar curve arises in factor IX deficiency patients also, where for those who are less than 1%, we see a marked increase of annual joint bleeds. And then moving a patient from less than 1% to in the 1 to 5% range, especially as you get over 2 or 3%, markedly decreases bleed rates. And then as you get over 5%, it doesn't immediately go to 0 in the mild hemophilia range, but as you get higher, up over 10%, it begins to approximate 0 in large populations. So moving from all of these patients from severe even into the moderate category, and as I mentioned, in some cases into the mild category, really improved their hemophilia. And we could actually see that there was a marked reduction in bleed events in all dose levels. And so this is a bit of a busy figure, but what it shows is the number of bleeding episodes per year going up and down on the y-axis, and then looks at 4 patient groups across the bottom, across the x-axis. So the first panel in gray looks at the average number of, this line here, the average number of, or the 50th percentile of bleeding episodes for all of the patients before gene therapy. You can see the median, the 50th percentile, was somewhere between 1 and 2, but in some cases it was up over 3, and in some cases a little bit lower because of averages. But then when you look at all of the patients after gene therapy, you can appreciate the dramatic drop in this 50th percentile range. So there were still some people that had some bleeding episodes, which wasn't surprising given that several of them were in the moderate range, but you can see the marked reduction in number of bleed events. And when you restrict the analysis to just those in the high dose group, so those were the ones in green with the overall best mean factor levels, you can see a very prominent reduction in the number of bleed events. And to correlate with this, we also see a number a marked decrease in the number of factor VIII units per kilo per year consumed. So with the same setup, you can see all patients before gene therapy and the decrease in factor consumed after gene therapy, and also for the high group. So really making a marked difference, fewer bleeds treated, fewer days missed from work, and fewer units of factor needed to be consumed. So because of this early excitement, the landscape of gene therapy for hemophilia B sort of exploded. And so I've listed here a number of manufacturers and the gene therapy products that have either recently been in trials or currently in trials. And the exciting thing that you see is many of these have moved from just academic investigators, people at institutions of higher learning and hospitals who may have started small biotech companies to support their early research and findings. And we now see larger pharmaceutical companies such as Shire and Pfizer partnering and participating in the gene therapy trials. As I mentioned, there's a number here. I will just put a little star next to Single Well Biosciences. I do consider them in the landscape of current gene therapy. However, they are a gene editing technology, and so we won't discuss them much further. The other thing you'll notice is that I have grayed out Bax355. So while Shire continues to be interested in gene therapy for both hemophilia A and hemophilia B, this particular product is not currently being investigated any longer. So how did we end up with so many different gene therapy products and so many different trials? Does that even make sense? And the answer is absolutely. And the places that we actually see the difference amongst these trials are in some of the details of the AAV vector, as well as in details of the expression cassette. And so I just sort of repeated the list that we saw on the previous slide and then added in just a touch of information to give you a sense of how the AAV vectors differ, and then also how those expression cassettes differ. The main thing to realize is that there's a few different types of AAV vectors that hone to the liver and that are potentially successful for hemophilia B as well as hemophilia A gene therapy. Some of these are based really closely on just the specific AAV. In some cases, investigators have taken all of their knowledge about the genetics of AAV and really constructed their own variant of AAV, and a lot of the details of how vectors have been slightly modified to improve their longevity, to improve how well they go to the cells that we're trying to target, to improve their uptake, is proprietary for the different companies. And similarly, the expression cassette, where tweaks can be made to the promoter region, potentially also to the coding sequence for the gene construct for either factor IX or factor VIII. Some of those little in-between places I mentioned where modifications can be made. Changes have been made in all of those places and differ for the most part among all of these trials in an attempt to do the very best they can to get the gene product where it needs to be and optimize the expression. And this is actually really important because not all gene therapies may work for any given individual. And so learning about, in parallel, how all of these different modifications may contribute to one or more very successful products is an important part of the development and of us improving therapies for both hemophilia B and hemophilia A. So to tell you a little bit about the trials, I'll start first with Dimension Therapeutics. And I use them as sort of a construct for just giving you an overview of how gene therapy trials are laid out in general. There's some variation in the exact inclusion-exclusion criteria in some cases. There's some variation in the dosing selections made. But most gene therapy trials follow a very similar format. Because they're early, and in many cases, this is the first patient group that they're being explored in, safety of this, as well as finding the optimal dose, really a first-line priority. And so we often refer to those types of trials that are early in development. We're looking at safety, looking for the right dose as phase 1 trials, in some cases phase 1-2, depending on the design. Gene therapy trials at this point are focused really in adult patients, so people who are 18 years of age and older and have moderate to severe hemophilia. So the cutoff in general has been less than or equal to 2% of baseline factor IX levels. You can see here the dose ranging. So similar to the first study I showed you from the New England Journal, trials start at a low dose and then they increase their dose to as long as there is no safety signal, as long as things look like they're going well, to see if they can increase the effect. And the goal is to treat patients with a single peripheral infusion. The primary aims are really about the safety, and here I've listed DTX101, but you could substitute for the early phase trials any one of those manufacturer examples I gave you of the gene therapy construct. And they're all looking to see the peak plasma levels that they're able to deliver and at what time point they're meeting those plasma levels. And then in addition, we're looking at number of bleeding episodes that require ongoing factor IX infusions. If patients have previously been on prophylaxis, how many fewer doses are they able to take? How does the body respond to the gene therapy? Are there any immune responses to the gene therapy? And what is the overall impact on a patient or participant's quality of life? Do they have fewer bleeds? Do they require less factor IX? Are they more active as a result? Do they feel better as a result? So the general design is, as I mentioned, patients are enrolled in the first dosing cohort. They're monitored really carefully for any signs of toxicity or adverse symptoms. Their factor IX levels are also monitored. And then after a certain interval of time that's predetermined by the person running the trial, there will be a committee that is not related to the manufacturer, that's not related to any of the institutions conducting the trial, that looks at all of the data to confirm whether or not everything looks like it's going as expected and to confirm whether or not there seems to be any concern for safety or patient health. And if everything is looking good and we want to push to see if we can get a better response, depending on what it looked like in the first cohort, then people would move on to the second cohort and so on for the next cohort. Once you get to the cohort where you think you have hit your maximum dose or your maximum effect, then often a few additional patients will be added at that level to give more credibility to the data, to understand the slightly larger population if those findings continue to persist. So Baxalta/Shire, as I mentioned, this program has semi-recently closed, but has presented some of their data in mirror fashion to what we saw with the New England Journal paper by Methwani. They also used 3 dosing groups. And what you can see is in that low dosing group, one person essentially had no response. There was a very slight response in subject number 2. In the middle dosing group, 2 people ultimately had no responses, but one person actually shot up to a factor IX level of 20%, so well in the mild range. And then again in the high dose cohort, over time, patients did not sustain any factor levels. And when we dig a little deeper into what some of these patient profiles look like, what we can see is for this one patient, for example, after the infusion, here at just after baseline, indicated by this blue arrow, the dark blue line demonstrates an increase in factor IX activities. You can see shortly after the gene therapy, we were seeing a nice increase in factor IX. There was a little bit of change here, but overall the patient made it up to around their 20% range, and at least as far as we have had data presented to us, was able to maintain that factor IX activity level. In gold, you can see something called the ALT, and this is a liver enzyme that can be a marker of inflammation. And what you can see here is this person's ALT actually stayed within normal limits the whole time. This is in contrast to another patient who, after receiving gene therapy, similar to the first, actually had quite a robust response and had a factor level as high as 60%. Unfortunately, we then see the factor level plummet and never quite recover. At the same time, in gold, what we can see is initially this patient's liver enzyme, the ALT, was quite normal, but then it began to rise, and it began to rise pretty coincident with this drop in factor IX level. And so what people have realized, and this was true for several gene therapy studies, that there seems to be some type of inflammatory response happening within the liver that causes the production of factor IX, or potentially the cells that have the right DNA for factor IX, to either stop producing or to be destroyed, such that we lose the effect. The interesting thing is that while we see that this lab changes, patients who this has happened to actually have no symptoms. So there's no fever, no feeling unwell, no belly pain, no symptoms. But this lab has been followed very closely, and we see this relationship. In response, some people have either from the beginning or at some point during the course following the gene therapy have started steroids such as prednisone to try to dampen that inflammatory response to see if it helps. In this particular case, we see that the factor IX level continued to decrease. It didn't go back to less than 1%, but decreased right into the moderate range. In other cases, following prednisone, we have seen factor IX levels actually recover and maintain themselves in the mild range. So exactly what causes this inflammatory response, which cells of the immune system are mediating it, and the best way to treat and prevent it is still being investigated in some cases. unicure is another company that has several patients who've been treated with AAV gene therapy. They're using a slightly different AAV molecule than some of the other gene therapy manufacturers. This graph really represents their first dose cohort. And what you can see is that of the 5 patients treated, 4 of them were actually able to achieve and maintain levels in really in the moderate to mild range. So this seems to recapitulate some of the early data that I presented to you from the New England Journal paper by Nefwani, and this seems to be maintained. They also recently have via press release put out data from their second dose cohort, so their next highest dose for another 5 patients. And while this data is relatively young, meaning that patients haven't been treated for too long following the infusion, over the course of the first 6 months or so, they have seen an average steady state level of right around 7% for the 5. So that means there will be people that will have higher factor IX levels. There will be people that have lower factor IX levels. And the details of the data we're excited to see presented hopefully at some point soon. I think Spark Therapeutics has perhaps made the biggest splash in the gene therapy community, particularly for factor IX. Many of you may have seen or heard about the Spark Therapeutics data from the World Federation meeting this summer. They just recently presented additional patients and longer follow-up data at our National Hematology meeting at the American Society of Hematology. And this is a figure of the data they presented. So similar to the other studies, on the y-axis we have factor IX levels. On the x-axis we have days after administration. And you can see that each of these 7 patients pretty quickly rose with factor IX levels and had a steady increase over the first 50 or 60 days, and then some have plateaued. Amazingly, all of these patients have factor levels near or above 20%, and the vast majority seem to sit somewhere in the 20 to 40% range. So this is exciting. This is well in the mild range, and as you can appreciate, hopefully actually much better than many of the other gene therapy trials that we've seen published data so far. I think some of the unique things about the Spark patients are, one, I had mentioned that they have their own proprietary AAV vector. Like the other companies, they've made modifications to their expression cassette. They also have used the lowest dose of gene therapy so far. So there is something about the way they've constructed their vector, their expression cassette, that allows them to have what seem like pretty excellent results, even with the smallest dose of gene therapy administered. So we often in medicine, we think, more is better. Once I give a dose, if patients aren't sick, let me push higher, et cetera. They really took the strategy of saying, we see that as doses increase, people are running into trouble with this inflammatory response that's a bit difficult to characterize. So patients aren't having any symptoms. We see that liver enzyme, that ALT, is rising, that people are losing expression. Let's make all the modifications we can to get the best expression of factor IX with the minimum amount of gene therapy possible to try to avoid that inflammatory response. And in fact, none of these patients were placed on steroids, and none of these patients had that immune response that we have seen in other gene therapy trials that then caused them to lose expression. I also want to touch, before we close, on the current landscape of hemophilia A gene therapy. This list is a bit shorter. So at the top, I put back our friendly photo of our adeno-associated viral vector along with the expression cassette. And I point out here that the max that's listed is 1.4 kilobases. So for something like the factor IX gene, this is not a problem because factor IX is actually a relatively small gene, around 1.5 kilobases. Factor VIII poses a challenge because it's actually quite a bit larger. It's 7 kilobases. So there is no squeezing a full factor VIII gene into an AAV expression cassette. At the same time, AAV gene therapy is really appealing because of all of the things that we've mentioned about being able to just do a one-time infusion into a person. You don't have to go through the additional steps and risk of cell-based therapy. There is ongoing, safety data from not only hemophilia, past hemophilia trials, but also AAV clinical trials and a number of other diseases, so a bit different from the novel and interesting gene editing technology trials that are a bit newer across all disease types. So if we were able to find a way to put 8 into AAV, that would be really tremendous. And so the first manufacturer who's been able to successfully do this and actually has gene therapy trials for factor VIII up and running is BioMarin. And part of the way they were able to achieve this is by cutting out the B domain. So they used a gene construct that was similar to that used to make a recombinant factor VIII product for Facto. And so by taking out the beta domain from the gene sequence, as well as making other modifications, as we spoke about for the Hemophilia B gene therapy, they were able to come up with the DNA sequence for factor VIII that actually just fits within the expression cassette that we can use for an AAV therapy. And they have posted some initial results as well. They moved pretty quickly from a low dose group up to the high dose group. This was data that they had initially released in April of 2016. Since that time, they've actually added an additional patient to the cohort. So what you can see is back in April, the overall follow-up was relatively short, so 5 or 6 or 7 weeks, et cetera, since the time of infusion that they were reporting out these factor VIII expression levels. What is potentially exciting, though, while we don't see much of an increase in factor VIII levels at the lower doses, in this higher dose cohort, we see some very respectable factor VIII levels that are, for the most part, in the mild range, and in some cases, actually even in the normal range. Additional data that they have released relatively recently in a press release noted that actually 6 of these 7 patients, as I mentioned, there has now been one added, so 6 of the 7 patients actually have factor levels greater than 50%, and the 7th patient has factor levels greater than 10, factor VIII levels greater than 10%. Interestingly, and we'll have to see how this plays out over time, the 4 patients who have been followed the longest, at least 20 weeks, had an average factor VIII level of about 146%, and 2 patients actually had factor VIII levels greater than 200%. So I think most of you will recognize that we generally consider the normal range to be 50 to 150%. Certainly because of that wide range and because of the role factor VIII plays, there is a pretty wide safety margin in terms of the overall desired factor VIII level. But amazingly, many of these patients have actually, exceeded even the normal range, having factor levels up over 200%. So far, the gene therapy has been tolerated really well. Similar to the SPARK presentation, none of these patients had significant increases in their ALT. All of these patients, at least in the high dose range, however, were just empirically upfront started on steroid therapy to help dampen the immune response. So that may have played a role also, but seems to have resulted in, at least short term, in some effective factor IX levels. So we'll be really interested to see ongoing data coming from BioMarin in the factor VIII trial. Additionally, many of the other manufacturers that I mentioned for the hemophilia B trials also anticipate a program in hemophilia A and factor VIII deficiency. And so likely over the next 12 to 18 months, we'll begin to see additional factor VIII gene therapy trials become available for patients. There are just a few challenges for gene therapy. So one of the main challenges that we reviewed is getting the gene to the right cell type and in the sufficient quantity. And so this speaks to why it's important to have the right AAV vector and why it's important to optimize it. Just injecting it into the bloodstream, if it doesn't home to the liver, if it doesn't invade well, then everything will just get destroyed in a person's blood and you won't have success. We need to be sure that the gene is switched on. And so just because we get the DNA into the cell, we have to be sure that the cell doesn't just degrade that DNA, but instead actually uses it to make protein. Our immune system is a wonderful thing because it protects us from foreign invaders. But in some cases, when we're trying to use foreign invasion as a mechanism for treating disease, the body's immune system can be challenging for us. So while AAV does not cause human disease, it is a virus that is around in our everyday environment. So many people have been exposed to AAV, though they've had no symptoms. And as a response, their body has made antibodies to fight it off, even though there's no resulting symptoms. And so 30 or 40% of the population may not even be eligible for some of the gene therapy trials because they may already have antibodies existing in their blood, which would neutralize the gene therapy product as soon as it was administered. So part of the reason it's actually exciting to see many different approaches to gene therapy and why it's important to continue to support a number of gene therapy programs, even with some of the early successes, is not every person may be eligible for the vector of a certain gene therapy trial. And even hopefully once things are approved and commercialized, that will continue to be true. So we may need multiple gene therapy products available in order to treat the maximum number of hemophilia patients. Similarly, once a person has had gene therapy, there does seem to be an adaptive immune response. So just as though you had got it just naturally in your environment, once we inject an AAV virus into a person, their immune system will respond to it and will develop antibodies. And that generally, at least for now, prevents them from being able to have a second dose of the exact same gene therapy. Loss of episomes after cell replication. So one of the wonderful things, especially about our youngest patients, is that they are still growing. Their cells are dividing all of the time. And as I mentioned, we like the fact that with AAV, the vast majority of DNA doesn't integrate. It just sits in the nucleus of the cell, uses that machinery because there's a safety factor there. At the same time, if you're not actually incorporated into the person's own DNA, when the cell goes through its usual mechanisms for dividing and maintaining its DNA, you get lost in the shuffle and you are not copied and passed on to daughter cells. So potentially in our youngest patients who have the most cell divisions to go, we may find that AAV therapy doesn't sustain for as long as we would like. So far in the adult population and also in animal populations, this hasn't proven to be much of a concern, but it may be something that becomes of more interest as we get to younger and younger patients. And then certainly, as I mentioned, avoiding disruption of other genes and negative consequences from that is really important. So this is just a quick pictorial of gene therapy, perhaps in its simplest form. So the take-home points really from today are: one, gene therapy allows us to give cells, specific cells, not all the cells in the body, but specific cells, DNA instructions in order to make specific protein. And for our purposes, we're specifically looking at factor VIII and factor IX proteins. Fortunately, we have several methods to introduce genes into specific cell types, and each of them are being studied in hemophilia. AAV approaches are really the furthest in development, and that's true for both factor VIII and factor IX. But there is a lot of exciting data coming from cell-based therapies in hemophilia, as well as gene editing technologies in hemophilia. So definitely pay close attention, and we'll likely, over the course of the next year or two, need additional webinars to speak about the advances that are being made in these other technologies as well. And based on the data that has so far been presented, particularly from Spark, particularly from BioMarin, it's really the most hopeful I think we have been to date about gene therapy and its potential success for hemophilia to, at the very least, increase into the mild range, if not completely normalize factor levels. So with that, I would like to end and say thank you. If you have any questions about the presentation or about gene therapy, considering participating in a gene therapy trial, please do not hesitate to reach out. And certainly, if you happen to have a question at present and you type it in, I'll be happy to take questions from Rich and Heather. Thank you so much.
Thank you so much, Dr. Croteau. That was simply amazing. It's such an exciting time in our community, and you did such a fantastic job going overview. So much information, not just about gene therapy, but about where we're going. It's 1:02. We have time, about 5 minutes for questions. If you have a question, there is the box on the right-hand side of your page. Please type it in there, and we will ask Dr. Croteau the questions that you have. We did have one come up that we would hope that you can address, and that is, in the time frame, when do you expect hemophilia B and then hemophilia A to possibly hit the market in terms of having access after clinical trials for patients regarding gene therapy?
That's an excellent question. So based on some of the results that we've seen so far, I believe that Spark Therapeutics seems to be the furthest along of the current gene therapy manufacturers. And I would anticipate that based on the results they presented so far, they're looking to move forward to the phase 3 clinical trial. And a phase 3 clinical trial is sometimes called a pivotal trial. It's really the big trial that gets submitted to the FDA in hopes of licensure of a product. So we're actually probably a few years away from having a product that would be potentially licensed for gene therapy in hemophilia B for patients 18 and older, because generally it takes several months, if not a year or two, to really finalize a big protocol for a pivotal trial. It then takes, in many cases, a number of years, another year or two, potentially longer, to recruit all of the patients that we need to collect data on to learn more about the gene therapy trials and the outcomes and the safety data and the efficacy. And then it sometimes takes the FDA a year to review all of those final results and make a determination about whether or not to grant licensure and approval to a certain product. So we're definitely the closest we've ever been, and I think we're moving there, but we're still several years away from being able to take hemophilia B gene therapy off the shelf for patients not participating in a clinical trial. And the same would be true, but that much more delayed for hemophilia A, where at the present we only have one phase 1 early phase trial. So that development has additional steps that it would need to make before it could get to that big phase 3 trial.
Fantastic. Thank you so much. We just had another question come in. The question is, since a lot of these trials are showing levels still in the mild range, how do you expect that to work as a physician, that this is not curing hemophilia, but it's putting people in that mild hemophilia range in terms of treatment and making sure that patients do not remain complacent because they still are living with a bleeding disorder?
That's a really great question. So in the best of all possible worlds, we would have gene therapy that cures hemophilia. In the absence of that, I think for many patients, even changing their hemophilia diagnosis from a severe hemophilia diagnosis to a moderate or mild severe hemophilia diagnosis can actually have a pretty dramatic impact on their life. Certainly, if you're exchanging a severe diagnosis only getting to 2 or 3% or 5 or 7%, you're still going to be dependent on factor, particularly for injuries, for around surgery. But generally speaking, particularly for those who are 5% or greater, it would likely alleviate the need for prophylaxis as we currently do it, because most patients with prophylaxis are at best staying above 1 or 2%, and in some cases are staying in the 4 to 5% range. So it may help at least decrease the burden of needing to infuse quite so regularly, but not eliminate the burden of hemophilia infusions overall. For some patients, they're very active, and they would likely tell me, doc, I would rather do my infusions and have times where I'm in the normal range or essentially in the normal range and more well protected, so I can play soccer a few times a week, or do my athletic activity of choice and have better coverage than just living at 5% or 2% all the time. And so for them, they may say, until it's either much better or if this is the best that you've got, this other strategy works better for me. On the other hand, there are some people who, for a variety of reasons, do just fine at 3-5% because of their lifestyle. They may not be quite the same athletic types, and so they would have no bleeding issues, again with the exception of an injury or surgery, just living at that level without having to infuse with any kind of regularity. And those patients also may be those who may or may not just not like infusions. Not that anyone likes infusions, but for some, it's much more problematic to build it into their schedule, to remember to take the infusions on a regular basis. And so moving up to even just a few percentage points to give better baseline coverage might actually dramatically reduce their bleeds and decrease the burden of their disease on them.
Fantastic. Thank you so much. We are out of time. We want to express our sincere thanks and gratitude to Dr. Croteau for spending time with us this afternoon, and for everyone for being on this webinar. A recording of it will be available via NEHA's YouTube channel over the next couple of weeks. So please pass it along to family and friends who may have missed this today. We also want to remind you that there's another webinar coming up on Monday, January 9th at 7 p.m. It will be a year in review for NEHA and a look ahead at 2017 dates. And building on today's webinar, we also want to make sure that you saw that NEHA will be hosting a one-day medical update. This is for consumers in the bleeding disorder community to learn more about gene therapy and other potential treatments that are in clinical trials. And that's going to be on Saturday, March 25th from 8 to 4 p.m. in Portsmouth, New Hampshire. Registration for this important event will be opening soon. Thank you, everyone, for joining. Thank you, Dr. Croteau, and happy holidays, everybody.